I'm Tom Stavros. I'm a breast and women's imaging radiologist. I'm from the Sutter North Bay Women's Health Center in Santa Rosa, but for years I was with the Sally Joe Breast Center, so most of my images are from Sally Joe Breast Center. I'm going to talk to you today about evaluating the regional lymph nodes of the breast as an extension of the breast ultrasound exam. This is perhaps the area where breast ultrasound has changed the most in recent years. Today I'm going to tell you about evaluating regional lymph nodes as an extension of the breast ultrasound examination. In our practice, we've evolved to evaluating the lymph nodes in every patient in whom we detect a suspicious a BIRADS 4 lesion or a definitely malignant BIRADS 5 lesion in the breast, upon whom we are going to do minimally invasive breast biopsy as part of the staging procedure. So we'll look at the axillary lymph nodes, we'll look at the internal mammary lymph nodes, and we will perform a core needle biopsy on all abnormal lymph nodes, although we will admit that an FNA would suffice in many cases. We do not biopsy sonographically normal lymph nodes, and as a further extension of that, I would say we try to minimize biopsying benign reactive nodes that might be morphologically abnormal. So we try to do this evaluation at two different levels. Number one, is the lymph node normal or abnormal? And number two, if not normal, is it more likely reactive or metastatic? And we'll talk about why in a minute. By evaluating the lymph nodes in a patient with a suspicious breast nodule, ultrasound is the best examination. At this time, it is better than either CT or MR, although with recent advent of sub-millimeter isovolumetric MR is getting more competitive. There is a contrast agent for MR that hasn't been approved called Combidex that could also make MR more competitive. But at the present time, ultrasound is still the best way to look at the regional lymph nodes. The principles of evaluating the regional lymph nodes of the breast are very similar to evaluating any superficial lymph node, and we've learned a lot from the thyroid clinic and head and neck lymph node evaluation. Ultrasound is going to get better at this, but MR probably will too. CT probably doesn't have much hope of competing. Ways in which ultrasound can get better are with selected contrast agents, which we'll talk about later. There's one called sinusoid that again is not approved but looks very promising. And elastography may help us distinguish the reactive from the metastatic lymph nodes. Now, normal lymph nodes look like miniature kidneys. In the long axis, they're elliptical with a hypoechoic cortex and a hilum or mediastinum of variable echogenicity and a thin echogenic capsule. In the short axis view, they're more C-shaped, obviously, and they open up on the hilar side. This is a grayscale image, long axis of a normal lymph node, and this is a short axis showing the C-shaped hypoechoic cortex and the variable echogenicity within the mediastinum that opens up on the right side of the image as I'm illustrating with the arrow. Now, even though lymph nodes look like miniature kidneys, there is a difference. In the kidney, everything, the arterial flow, the venous flow, the lymphatic flow, as well as the collecting system of the kidney, enter or exit through the mediastinum. In the lymph node, the arterial vessels that feed the lymph node, the venous vessels that drain the lymph node, and the efferent lymphatics exit through the mediastinum or the hilum, but the afferent lymphatics come in through the cortex. Now on the top here I've shown a histologic image of a lymph node, and this wavy little red line in the near field, or the upper end of the image that I'm illustrating with my arrow, is the capsule of the lymph node. So if the afferent lymphatics enter from the periphery, they will enter through the capsule. I've converted this to grayscale now so it'll look more like the ultrasound. And you can see the arrows that I'm demonstrating. They're showing flow within the subcapsular sinusoids, and that's the pattern or the direction in which the lymph flow occurs. It goes through the subcapsular sinusoids, then through the cortical sinusoids, which are flowing between these big black circles, which are the lymphoid follicles, and then through the medullary sinusoids, which lie between the medullary cords. So this band of tissue here, and this band of tissue here, and this band of tissue here, and this tissue here, those are medullary cords. The flow is then toward the hilum and out through the efferent lymphatics. Now, what I've shown on the left is a 3-zone lymph node. So the hypoechoic cortex shown between the two white lines corresponds to the very large lymphoid follicles. Lymphoid tissue is fairly homogeneous, has few interfaces. Lymph cells are mostly water, so the sound transmission is quite good. So the cortex of the lymph node is the hypoechoic part. Between the two yellow lines now, I'm showing in white in this upper image, is the hyperechoic band of the kidney that is the medulla or the medullary zone. Why is it hyperechoic? It's caused by the interfaces between the medullary cords and the medullary sinusoids, and so all those interfaces create the hyperechogenicity. And the inner part of the lymph node that I'm showing with an asterisk is a mid-level gray, because now we're mostly seeing fat that's insinuated itself into the mediastinum or hilum of the lymph node, and some vessels that flow through that area. Now in young patients, or patients who have never had a lot of inflammation, the cortex remains hypoechoic, but the hyperechoic medulla may fill the entire mediastinum or hilum of the lymph node. As patients get older, or as they have repeated inflammatory episodes, the lymph nodes tend to undergo lipomatous or lipogranulomatous atrophy, and fat tends to insinuate itself into the hilum. The cortex becomes relatively thinner and more atrophic, and the medulla gets compressed into a thin band of hyperechogenicity just deep to the cortex. And the mediastinum gets progressively more infiltrated with fat. And on the right, I'm showing just a more atrophic lymph node with more fatty infiltration. Two things are evident from this. Number one, we recognize that on a mammogram, lymph nodes have a fatty hilum, and we recognize on ultrasound that fat is isoechoic or mid-level gray. So we had this discrepancy of why something that should be fatty is hyperechoic rather than isoechoic on ultrasound. And the explanation is that the hyperechogenicity is not the fat, but simply the interfaces between the medullary cords and sinusoids. And the second point that this makes is that the largest lymph nodes we see tend to be those that are infiltrated with fat and have infinitesimally small cortex. And this is going to be the reason that size correlates very poorly with the presence of metastasis. And we'll talk about more about the mechanism of abnormality within the lymph node in metastatic disease. Size does not work because the largest lymph nodes have thin cortex. Now, for reasons that I don't understand completely, metastases tend to implant within the subcapsular or cortical sinusoids. And the appearance of the cortical thickening caused by metastases depends on where the metastases implant and how extensively they implant. Now, the most common place for a metastasis to implant is in the cortical sinusoids between the lymphoid follicles. And when it does that, it causes a certain appearance. Probably the second most common place is to implant within the subcapsular sinusoids, and that causes a different appearance. But you can also get implantation in the deep cortical sinusoids right at its junction with the medulla, and that causes yet a different appearance. So we'll go over those individual appearances. So we'll start again with our color histologic image, and we'll demonstrate that in a patient who has multiple metastases in the cortical sinusoids, you can get cortical thickening that is uniform and enlarges the cortex through an entire lymph node, or it can be focal. In this case, I'm illustrating a focal cortical thickening. This is the hallmark of metastatic disease. You can see that in this case, the bulge is approximately equal inward and outward. And on the left real image, you can see a focal cortical thickening that I'm outlining by the white line, and you can see that compared to the yellow line, which is where I would interpolate the normal outline of that lymph node to be, it's approximately equal inward and outward. This is the hallmark of metastatic disease. Eccentric or asymmetric cortical thickening within a single lymph node is metastatic disease until proven otherwise, and we should specifically target this area of the lymph node for either FNA or core biopsy to document the presence of metastatic disease. Now, there are cases where the cortical thickening involves the entire lymph node. This is abnormal. What is the normal thickness of the cortex in a lymph node? Well, there's a range of numbers that have been published from about 2.1 millimeters up to 4, but I'd just like to take the middle of that range and use more than 3 millimeters as abnormal cortical thickening. The important thing about this diffuse or completely symmetrical cortical thickening around the entire periphery of a lymph node is that it is nonspecific. When we see this, we know that the lymph node is not normal, but we don't know whether it's reactive or metastatic. And as I said at the very beginning, we would like, to the greatest extent possible, be sure that this is likely to be a metastatic rather than a reactive benign lymph node before we do biopsy on it. So we're going to have to rely on some tiebreakers. Those tiebreakers could be Doppler, but they could simply be the relationship to adjacent lymph nodes or contralateral lymph nodes, and we'll talk about that later. Now, when the metastatic lesion implants primarily along the subcapsular sinusoid, the cortex bulge is going to be primarily outward, as I'm illustrating on the right lower image. Here's a demonstration of that in a native lymph node. The yellow line is showing the interpolated outline of where the lymph node would be, and the white line is emphasizing the eccentrically thickened lymph node bulging to the outer side in almost a Mickey Mouse-like ear appearance. Here's another case. Notice that the bulge is almost completely outward, illustrated by the white line. This is simply a manifestation of the implantation site being in the subcapsular sinusoid rather than the cortical sinusoid. But this is highly suspicious for metastatic disease. It would do no good to biopsy this part of the lymph node because the metastasis lies within the cortical thickening. This is the part of the lymph node that should be targeted for biopsy. This is an illustration of an implantation site of a metastasis more toward the inner side of the cortical sinusoids at their junction with the medullary sinusoids. And as you might expect, the bulge from this kind of metastasis is primarily going to be inwardly into the hilum of the lymph node, and we're illustrating that in the right lower quadrant. What I'm showing on the left is a normal lymph node, but now here's one that has a metastasis that primarily bulges inward. I've outlined the native shape of the lymph node with the yellow line, and you see the white line shows primarily inward bulge, although this one is so large that it now has an outward bulge as well. But this is what we call a rat bite indentation into the hilum. So in summary, cortical thickening can vary in appearance depending upon whether the implantation site was primarily subcapsular, within the mid-cortex, or on the deeper part of the cortex, because the bulge will be equal if it's in the cortical sinusoids, primarily outward if it's in the subcapsular sinusoids, or primarily inward into the hilum if it's in the deep cortical sinusoids. Now, occasionally we can see tumor distended lymphatics. Usually there is also evidence of perinodal invasion. And here we're seeing some distended lymphatics. There's more than one afferent lymphatic that comes into the lymph node, and so sometimes, especially if we do 3D reconstructions, we can find these. That's usually associated with perinodal invasion. Now, there are certain times when the presence of lymph node metastases are going to be higher. And on the left, I've shown a case from Laszlo Tabar's 3D data. I haven't documented that Laszlo let me use this image, but this should say Laszlo Tabar on the bottom. But this is invasive lobular carcinoma invading up Cooper's ligament to the superficial fascia. We believe that most of the skin drains down to lymphatic channels right along the superficial surface of the superficial fascia. And most of the deep lymphatics go upward toward the superficial fascia. And then there's a rich network of lymphatics along the superficial fascia, some of which we're seeing here distended with tumor. So basically, if you have either a very superficial cancer in the breast that lies near the superficial fascia or near the periareolar Sappi's plexus, there's a much higher chance of metastatic disease. Or if you have a deep lesion, as we're seeing here, that's growing up Cooper's ligament toward the skin, then you have a much higher chance of having lymph node invasion or lymphatic invasion and lymph node metastases. So you want to be especially aggressive about evaluating the lymph nodes, the regional lymph nodes of the breast, when you have a very superficial lesion or a lesion that's growing up Cooper's ligament to the level of the superficial fascia. Here's a 3D reconstruction of a distended lymphatic channel within the superficial subcutaneous tissues and multiple nodules in the subcutaneous tissues from a very extensive lesion that has got lymphatic invasion and positive lymph nodes. When you see these distended lymphatics or multiple satellite nodules that lie at the level of the superficial fascia, which is where the Cooper's ligaments hook in, there's almost 100% chance of metastases. This is simply a real-time loop through the case I just showed you. You can see all the subcutaneous nodules. It's really difficult to pick out the superficial fascia. It lies right here, but it's obscured by edema. But we can see that distended lymphatic and that it's not merely a Cooper's ligament because it's two-dimensional, not three-dimensional. Now, interestingly, foreign bodies tend to accumulate from the medullary sinusoids outward, so we can also see abnormal lymph nodes in people with ruptured implants. But notice that the dirty shadowing is within the hilum and the cortex is virtually preserved early on. Later on, the cortex may also be involved, but the key point here is that foreign bodies such as silicone tend to affect the lymph node from the medullary sinusoids outward, whereas metastases tend to affect the lymph node from the subcapsular and cortical sinusoids inwardly. So again, cortical thickening is the hallmark of metastatic disease. Here's a distended afferent lymphatic, which I showed you earlier, and here's a micrometastasis within the subcapsular sinusoid. Micrometastases are defined as under 2 millimeters, and we would not expect to see those with ultrasound. So if we look at a list of all the features that we can look at for abnormal lymph nodes, one of the numbers published is size, but a lot of the published literature is in CT, because size is about the only thing you can evaluate on CT. I will tell you now that size is a very poor criterion, and we rely almost entirely on morphology. Unless a lymph node is 3 or 4 centimeters and has huge cortical thickening, size isn't of much use. We see small metastatic nodes of 6 or 7 millimeters, and we can see perfectly normal fatty involuted lymph nodes that are 3 or 4 centimeters. If you insist upon using a size, 1 centimeter is the right number for axillary lymph nodes, but not necessarily for internal mammary. We'll talk about internal mammaries later. But remember, that's the minimum diameter of the lymph node, the minimum diameter, not the maximum diameter. If you're going to use any diameter, you have to look at the minimum diameter. Abnormal shape includes abnormal rounding of a lymph node. And clearly this is a valid finding with a high positive predictive value, but it's low sensitivity because the lymph node has to be almost completely replaced by metastatic disease before it becomes rounded, and cortical thickening occurs far before that. Abnormal echogenicity can be valuable in that metastases are often markedly hypoechoic compared to surrounding fat. But again, this is a variable finding, and if you use tissue harmonics, the lymph node cortex often appears markedly hypoechoic, so this finding is of less value. I do use harmonic in all cases because I can find more lymph nodes faster with harmonics than I can without. So I don't use hypoechogenicity as a finding. What I rely upon primarily is morphology. Eccentric cortical thickening is the hallmark of metastatic disease. Hilar outward bulge in what we would call a Mickey Mouse ear is simply a manifestation of eccentric cortical thickening arising from the subcapsular sinusoids. Hilar indentation or a rat bite indentation is simply eccentric cortical thickening arising from the deep cortex and bulging primarily inward. Hilar compression or displacement can occur when the entire cortex is thickened, and depending on whether it's symmetrical or asymmetrical, it may favor a reactive or a metastatic node, so it's nonspecific. Hilar obliteration tends to favor metastatic disease, and if we get symmetrical cortical thickening, we have to go to our tiebreakers to decide whether this is more likely to be a reactive or metastatic node. So what we rely on as our first tiebreaker is not Doppler, but simply a grayscale imaging. You can usually show more than one lymph node in the axilla, and the relationship between adjacent lymph nodes can be important, and we'll talk about that more. We can also use right to left symmetry. Color Doppler flow patterns can be helpful, but I use that farther down the list, and pulse Doppler spectral waveforms can also be helpful. It's rare that I ever have to get to the third or fourth tiebreaker. I almost always make my decision based upon eccentric cortical thickening and the relationship between adjacent lymph nodes. So I generally use only the lymph node of interest and the adjacent lymph node to make my decision. Capsular loss or margin irregularity or perinodal edema all are suggestive of perinodal invasion, and we'll talk about why that's important, but in these cases you'll want to do specifically a core biopsy rather than just FNA. Of all these criteria, the least useful is size. And this is all CT has to offer is size. So you can see why I believe that ultrasound is infinitely better at evaluating lymph nodes than is CT, at least for superficial lymph nodes where we can get a good evaluation with ultrasound. Now this is just a demonstration of a normal axillary lymph node surrounded by normal axillary fat, done with fundamental imaging on the left side and coded harmonics, digitally encoded harmonics on the right. And you can see that the lymph node is clearly more hypoechoic with harmonics than without. It makes it easier to find the lymph node, but when you use harmonics, you shouldn't use hypoechogenicity as a finding because it's normal with harmonics. And again, I use harmonics in everybody because I can find more lymph nodes faster with harmonics. The only exception would be when there's a lot of edema or the lymph nodes are very deep. Sometimes I might not get adequate penetration with harmonics, and I'll do it without. This is sort of an illustration of when we need a tiebreaker and when we don't. In the center, I've shown a normal lymph node. In the left upper corner, I've shown symmetrical cortical thickening, and I've put a little white outline around this, meaning that it's nonspecific. This could just as likely be a reactive lymph node as it could a metastatic lymph node, so I'm going to have to rely on a tiebreaker. These two cases, I've put a pink box around, or a pink line around the images, because these should be viewed with caution. These are eccentric cortical thickenings, and these should be viewed as metastatic until proven otherwise. They should be biopsied whenever there's a BIRADS 4 or 5 lesion within the breast, and the area of cortical thickening should be specifically targeted. These have rat bite indentations into the mediastinum of the lymph node. There's also eccentric cortical thickening, and there usually is associated with this, but it might be symmetrical cortical thickening with rat bite indentations. This has a red line or a pink line around it, meaning it's metastatic disease till proven otherwise. These two lymph nodes have a compressed mediastinum. There is symmetrical cortical thickening, but it's so severe that the hilum or mediastinum is compressed to a thin line or a slit. This is still nonspecific. This occurs commonly in reactive nodes. So I've put a white line around it indicating that we need to look at our first tiebreaker and adjacent lymph node. Here's a case where the hilum is displaced out of the lymph node. This is very clearly the same as eccentric cortical thickening because the cortex is clearly thicker here than it is here, and I put a red line around it because that indicates metastatic disease until proven otherwise. This is a case where the hilum is completely obliterated. The lymph node is abnormally rounded as well. And if you wanted to use hypoechogenicity, it would be abnormally hypoechoic as well. On a theoretical basis, this could occur in necrotizing lymphadenitis, but a recent article just showed that 93% of lymph nodes with this appearance are metastatic. So I've put a red line indicating that it's metastatic disease till proven otherwise. And finally, in the top case, I've shown that the lymph node has lost its thin echogenic cortex that we see here, and here, and here, and it has angular or irregular margins. This is highly suspicious for perinodal invasion, and so I've put a red line indicating it's metastatic disease till proven otherwise. One case that wouldn't fit on the chart are the presence of microcalcifications within a lymph node. This tends to only occur when the primary lesion in the breast also has microcalcifications. So on the left, I'm showing the primary lesion. On the right, I'm showing a lymph node with microcalcifications. If this occurred in the neck, you'd think papillary thyroid cancer, but in the axilla, this is metastatic breast cancer until proven otherwise, and in a rare case, it might be due to metastatic ovarian cancer. But if the index lesion has calcifications, particularly casting or linear or branching calcifications, you may see similar type calcifications within a metastatic lymph node. And this is just a 3D illustration of calcifications, linear type calcifications within the cortex of a metastasis-bearing lymph node. Now I said that our first tiebreaker is to compare two adjacent lymph nodes. When do we do that? We do that when we get a nonspecific appearance of an abnormal lymph node in the axilla that could be either reactive or metastatic. So here's a patient with arm swelling. She had a lumpectomy 18 months ago, elected not to have axillary dissection. She indeed had arm edema. We looked and we saw symmetrical cortical thickening in this lymph node, but the adjacent lymph node has a normal thickness. This is also a hallmark of metastatic disease. So if you see unequal degrees of cortical thickening in two adjacent lymph nodes, it favors metastatic disease. Most reactive nodes are reacting either to the breast cancer itself or to some systemic or viral thing, and therefore the involvement tends to be more symmetrical. So here's another case, even more severe, perfectly normal looking lymph node on the left, and on the right we have a completely obliterated hilum. This would never happen in reactive lymph nodes. This is clearly going to be metastatic disease or lymphoma until proven otherwise. This might be a case if we didn't have a breast lesion where we'd want to do a core to make sure it wasn't Hodgkin's, but if we had a breast lesion, then we would assume it's metastatic disease and an FNA would suffice. Here we have two lymph nodes that are symmetrically involved. And I said symmetry favors reactive over metastatic, but when it's this severe, when it's so severe that we have obliteration of the hilum, we have to assume that's metastatic disease till proven otherwise. Now, which lymph node would I target for biopsy? When you see a complete obliteration of hilum, frequently there's so much necrosis you can't get an adequate cellularity on FNA or even an adequate specimen on core. So in these cases, I will sometimes target the lesser of the two nodes in terms of the degree of abnormality. Now here's a case where comparing to the adjacent lymph node doesn't help. We have two lymph nodes side by side with symmetrical moderate cortical thickening, and even after I compare to adjacent lymph nodes, it's still nonspecific. What would I do there? Well, oftentimes you can continue to rotate your probe around and find additional lymph nodes to compare to. So if I could find additional lymph nodes and there was asymmetric involvement of the two, then I would think metastatic disease. Or I could compare to the contralateral side. But this is still nonspecific with just that information. Here's a case where all of the lymph nodes on one side had symmetrical involvement. It didn't help me much, so we looked at the opposite side, and we can see clearly they were symmetrical right to left, and that favors metastatic disease. Now, if we go to our third tiebreaker, color Doppler, we just have to remember that 85% of the time the histology, the metastasis in a lymph node is identical to the histology in the primary. You'd think that would be 100%, but the literature doesn't support that. But anyway, what that means is if we have a hypervascular primary, the lymph node will tend to be hypervascular. Also, the waveform patterns, this would be our fourth tiebreaker, the pulse Doppler spectral waveform patterns between the primary and the lymph node tend to be similar. Now, the literature varies as to whether you should have high or low resistance patterns within a breast cancer, but the truth is, in the peritumoral tissues, you tend to have a low resistance pattern with rounded systolic peaks, but anytime you go into the center of a lesion, probably because of the oncotic pressure from stuff that leaks out of the abnormal leaky tumor vessels, you tend to have compressed sinusoids and you have a high peaky systolic flow and a high impedance pattern. So when the primary has that sort of a pattern from inside the tumor, you'll see a very similar pattern within the lymph node vessels. So high peaky systolic flow and high impedance flow is typical of metastatic disease. We can see here that this is a supraclavicular metastasis from breast cancer, and it has that high peaky systolic flow with a high impedance pattern, whereas a reactive lymph node tends to have a low rounded systolic peak and low impedance flow. Another thing that can be used is the pattern of vascularity on color or power Doppler. Reactive nodes tend to be fed by one or two arteries that enter through the hilum and then arborize to various degrees within the lesion and drained by veins that exit through the hilum, and you don't have transcapsular feeding or draining vessels. On the right, I've shown a small 7 millimeter lymph node that has severe cortical thickening. All we can see left of the hilum is a little slit, but this pattern is still not quite specific. The power Doppler shows not only is there a hilar feeding vessel shown by the H, but there are numerous transcapsular feeding vessels. Transcapsular feeding vessels strongly favor metastatic disease or high-grade lymphoma. The tumor implants in the subcapular sinusoids, and when it generates neovascularity from angiogenesis factors, it tends to generate those neovessels in the transcapsular areas. This is a reactive lymph node, and there's quite a bit of flow, and there's extensive arborization within the lymph node, but there's simply a hilar feeding vessel with no transcapsular feeding vessels. So if we want to summarize the combination of grayscale findings in color Doppler, in a reactive lymph node we tend to have symmetrical cortical thickening, as I'm showing on the left, and we tend to be fed by a single hilar artery and drained by a single hilar vein that enter and exit through the hilum, but no transcapsular feeding vessels. With metastasis, we have eccentric cortical thickening, displacement of the hilum out of the lymph node, abnormal hypogenicity, abnormal rounding, and we have multiple transcapsular feeding vessels in addition to the hilar feeding vessel in this case. This is just an example of how we would work up a patient. Here's a case of a BIRADS 5 lesion with microcalcifications. There's an abnormal lymph node that has symmetrical cortical thickening, so this could be reactive or benign. I'm not showing you the images, but we compared to the adjacent lymph node, which was normal. And here's the pre-fire core needle biopsy and the post-fire core needle biopsy, documenting the presence of metastatic disease. Now here's a lymph node with eccentric cortical thickening, and you can see that this is primarily an outward bulge of the cortex, telling us that the implantation site for this MET was primarily in the subcapsular sinusoid, but you can see there's pretty thin cortex along the deep side of this lymph node, pretty thin cortex here. It wouldn't do us any good to biopsy this part of the cortex. We specifically need to target the eccentric cortical thickening. You can see the pre-fire position of the needle and the post-fire position of the needle going through the eccentric cortical thickening, documenting the presence of metastatic disease in this lymph node. You could just as easily do FNA in that location. So this brings the question, is FNA adequate for biopsy of lymph nodes? And the answer is yes, in most cases. You can use FNA as opposed to core biopsy of lymph nodes. When would FNA not be good enough? Well, when we need to prove that there's perinodal invasion. So if we see loss of the capsule, angular margins, or peritumoral edema, or what look like distended afferent lymphatics, those things all suggest the presence of perinodal invasion. We would want to specifically do core biopsy. Here's an example of a lymph node with perinodal invasion on MR. Here it is on ultrasound. You can see that it has no capsule, it has markedly irregular margins, and it has peritumoral edema. So it has all the findings of perinodal invasion. What we want to do, and this is a long axis view of the same lymph node, here's another one, perinodal edema and a distended afferent lymphatic coming into the lymph node. Remember, the drainage pattern is from peripheral to central. So instead of just FNAing the cortex, we would like to specifically target the lymph node for core biopsy and put half of our aperture inside the lymph node and half out. So in this case, I would bring my aperture probably to the superficial side, so my illustration probably isn't correct, but you can see that the aperture is halfway in and halfway out. So when I fire my core device, I have some perinodal tissue, and then I specifically tell the pathologist that I'm concerned that there's perinodal invasion, and he will specifically report whether the lymph node is not only metastatic or not, but whether there's perinodal invasion. This is important to surgeons because in most cases, axillary dissection is simply a staging procedure, but in patients with perinodal invasion, they consider it a therapeutic treatment as well. Here's two adjacent abnormal lymph nodes. We could just FNA the one on the left, which may just show metastatic disease, but the one on the right clearly shows evidence of perinodal invasion. And so rather than do an FNA on lymph node number 1, I would specifically do core biopsy on lymph node number 2. And again, I would target it so that my aperture was half in and half out of the lymph node, and specifically tell the pathologist that I'm worried about perinodal invasion, so he would give me a definitive answer. There are a couple devices. I don't have any relationship with these companies, but the Achieve or the Temno needles allow me to pre-position the aperture before I fire, so I specifically like these for this particular indication. Will core biopsy of sentinel lymph nodes adversely affect a subsequent sentinel node procedure? If we get a positive biopsy, the sentinel node procedure is obviated, so that we won't need it. We'll go straight to axillary dissection, or the surgeon will go straight to axillary dissection. But if we get a negative biopsy, a sentinel node will still be present, so there's a theoretical possibility that a biopsy could disrupt the lymphatic flow patterns and give us a false negative sentinel node procedure. I don't think the risk of that is very great. First of all, we specifically target the cortex of the lymph node, not the hilum. And there are multiple afferent lymphatics coming in, so even if we hit one afferent lymphatic, we wouldn't hit all of the afferent lymphatics. And with FNA, you would probably even minimize that more. But the reality is the most common cause for false negatives in a sentinel node series is gross tumor disease that is so gross it completely obstructs the normal lymphatic channels and causes so-called tumor damming and collateral flow around the sentinel node. Those are exactly the lymph nodes that we're going to find easily and remove from the surgeon's sentinel node populations. So in theory, we should actually improve the surgeon's sentinel node statistics. Now, we do use ultrasound to guide sentinel node injections, and I'll tell you why in a minute. I don't think the periareolar intradermal injections are as accurate, and they do cause a higher false negative rate. I always believe that, but now there's some data to support that. We inject in the deep subcutaneous tissues over the nodule on ultrasound guidance. We usually inject at 4 equal aliquots. We use 4 aliquots of the cc each, and we place it at 12, 3, 6, and 9 over the nodule, not compared to the nipple, and not into the nodule or the biopsy cavity. The richest lymphatics are superficial to the lesion, so we intentionally inject superficial to the lesion. We do not use the periareolar intradermal injection. I'll show you why in a minute. I look for the sentinel node immediately after the procedure, and I try to mark the skin over it, and then I go back with a gamma counter later and document whether or not I was able to predict which was the sentinel node. And I found that about 90% of the time I am able to predict the sentinel node simply because it's the lowest lymph node we can identify. But about 10% of the time that's not true, so you still need to do the sentinel node procedure. In some cases, patients, and for some physicians, we actually needle loc the sentinel node as well as the index lesion. Now here is a recent article that came out showing why I think that periareolar intradermal injection is not as good as image-guided injection of the radionuclide in the deep subcutaneous tissues overlying the lesions. This group in England is publishing this in the Journal of Surgical Research, and the exact month and time isn't out yet. But what they did is they injected different radionuclides in the periareolar region and over the lesion, and then followed with imaging and gamma counters the flow of lymph nodes. And what they found was in 2/3 of the patients, it didn't matter whether you injected periareolar or over the lesion. They got to the same lymph node. But in 1/3 of patients, drainage from over the lesion and the periareolar region were different. And I think this is one of the reasons that we don't have a higher correlation of sentinel nodes. This is just an illustration. On the left shows what happens 2/3 of the time, and on the right, again, what could happen 1/3 of the time. The green arrow shows that the periareolar injection is going to lymph node 1, and the blue line simply shows that if we inject over the tumor, it goes to the same lymph node. 1/3 of the time, however, shown by the red on the right, the radionuclide went to different lymph nodes or even multiple different lymph nodes. So I think on a theoretical basis, well, not even theoretical anymore, but based on this study, I think that our subjective feeling that injection of the deep tissues over the lesion would be better has been validated. This is just showing our injection of radionuclide over the lesion. One thing I would caution you about, the syringe that you get with the radionuclide always has air in it. So you don't want to inject directly over the lesion immediately. I usually go past the lesion and put my first aliquot above the lesion because I know there's going to be air in the needle. And I can't squirt that out because I have radionuclide in there and that would contaminate the room. So I have to just live with the fact that I have air in the needle. So the best strategy is to go past the lesion. Usually we come in from inferiorly, superiorly, so I put the 12 o'clock aliquot in about 1 centimeter superior to the lesion first, and then I've got the air out of the needle, and then I do the 3 o'clock and 9 o'clock, and I do the 6 o'clock over the lower edge or inferior edge of the lesion last. This just shows us doing a needle loc. Here's the needle going through the sentinel node, and here's the wire going through it. Again, we've documented this with a gamma counter. And many times there are multiple nodes so close together you can't tell which is the node that is giving you the activity with the gamma counter. So in that case, we can shish kebab 2 or more lymph nodes on the end of a needle. This shows a typical case where we're doing a wire loc of the index lesion. You can see the hook on the wire going through the index lesion. And there's some air in front of it, which was placed there by the sentinel node injection. And here's the wire going in to localize the sentinel node. We also, at the time of core biopsy, deposit a clip in the lymph node so that the surgeon, if he chooses, can radiograph the lymph node and see if the little clip that we placed there is there. Why do we want to guide sentinel node procedures? Well, first of all, it makes it easier and quicker for the surgeons, and some might say that we're practicing for ultrasound-guided VA removal of the sentinel node, but at the present time that is not true. We use ultrasound to stage lymph nodes as well as possible. MR can do this with the correct sequences, but many of the MRs I see don't have the correct sequences and don't show the lymph nodes well. So the point is that if I see normal axillary 1 lymph nodes, I don't go to level 2 or level 3 or supraclavicular nodes because the Progression of metastases tends to be systematic from the lower to the higher nodes. But if I see a grossly abnormal level 1 node, I'm going to have to go to level 2, and if that's abnormal to level 3, I'm going to continuously have to go one level higher than the last level of grossly abnormal lymph node I've seen. We routinely scan level 1 axillary nodes and internal mammary nodes, but reserve level 2 and level 3 axillary nodes and supraclavicular nodes for cases where we have definite suspicion. Now, lymph node levels are determined by the pectoralis minor muscle, which is shown on this nice Netter diagram. The trapezoid here shows where the pectoralis would be. And basically, lymph nodes that lie inferior and lateral are level 1 nodes. Lymph nodes that lie behind the posterior or posterior to the pectoralis minor are level 2. And those that lie superior and medial are level 3, also called intraclavicular nodes. From there, the metastases may go to either internal jugular or supraclavicular nodes, so if these would be abnormal, we would look above the clavicle. Or if internal mammary nodes are positive, we would also look above the clavicle because you can get internal jugular lymph node metastases from there. So this is level 1, lateral and inferior to the pec minor, level 2 behind it, and level 3 superior and medial to it. This is an anti-radial view from the axillary segment of the breast showing the pectoralis minor and pectoralis major. And you can see that in the red box would be level 2. These would lie posterior to the pectoralis minor. Level 1 would be inferior and lateral to the lateral edge of the pectoralis minor. Notice also there's a little lymph node right between the pectoralis major and minor. This is a Rotter lymph node. There are multiple Rotter lymph nodes, and we can see normal Rotter lymph nodes in almost all patients, so just seeing them doesn't mean they're abnormal. Now, this is a case where there was a grossly abnormal level 1 lymph node that I'm showing over here by level 1. This is an extended field of view image showing the pectoralis major muscle in front, pectoralis minor muscle in back, and remember that this edge of the muscle on the right is the border between level 1 and level 2, so these two lymph nodes that lie behind the pectoralis minor are level 2 nodes. And this one is a level 3 node because it lies superior and medial to the superior medial border of the pectoralis minor. Notice it is also infraclavicular, and that's why level 3 nodes are also called infraclavicular. Since this is positive, I'm now going to go and scan the vessels, or the lymph nodes superior to the clavicle as well. Here's a patient in whom I found a supraclavicular node with microcalcifications, and I looked at the thyroid and it was stone cold normal, so I knew it couldn't be papillary thyroid cancer. So the next most likely cause for a supraclavicular node on the right that had microcalcs was breast cancer. So we came down and looked at the axillary lymph nodes, and you can see again the pec major is this long structure in front. The pec minor is outlined by the white oval. You can see that there's a huge node with microcalcifications that's a level 1 node. This was so fixed the patient couldn't elevate her arm, so we had to scan her with her arm down. I don't know how the clinicians didn't pick that up. Here's a level 2 node with microcalcifications lying directly behind the pec minor, and this white line shows the border between level 1 and level 2. And here's a level 3 lymph node with microcalcification. So this is metastatic disease of the breast that presented with a supraclavicular node with microcalcifications, but this is a nice outline of the lymph node levels. Now remember that the pectoralis muscles change with arm position, so the borderline between 1 and 2 can change. In the old days, the pathologist could determine whether a node was level 1 or level 2 because they got the pectoralis major and minor with a radical mastectomy. But even with modified radical mastectomy, the pathologist no longer gets a pectoralis minor muscle, so he doesn't really know the level of the lymph node. The surgeon has to determine it. The surgeon does the arm with the arm abducted at 90 degrees, so if we want to determine lymph node levels so that matches what the surgeon finds, we need to do it with the arm abducted exactly 90 degrees. Now this is a demonstration of a metastatic Rotter lymph node. In front we have the pectoralis major, and behind it we have the pectoralis minor, and this lymph node lies between the pec major and pec minor, and that's where Rotter nodes lie. So this is metastasis to a Rotter node. Notice also that there are two metastatic level 2 nodes behind the Rotter node. Now this just shows that we want to go one level higher. In another case of a metastatic breast cancer, we found level 1, level 2, level 3 positive lymph nodes, so we looked supraclavicular, they were abnormal. We looked internal jugular nodes, they were abnormal. And we went and we saw posterior cervical nodes, and they were abnormal. Now I don't need to biopsy every single level I see. I generally core the axillary node, level 1 axillary node, to document metastatic disease. And then I'll do FNA of the highest node that I find. So the highest node I found was a mid-level 3 posterior cervical lymph node. So I did FNA on that lymph node and documented metastatic disease there to outline the extent of disease. Now we do look at internal mammary lymph nodes in every patient. We can see normal internal mammary lymph nodes in most, but not all patients. We can't see the nice hilar structure in them. They tend to show up as small hypoechoic nodules, 5 to 7 millimeters in maximum diameter and 3 to 5 millimeters in AP dimension. So if I were to use diameter, I would use 5 millimeters in the AP dimension as an abnormal dimension. But this is a normal internal mammary lymph node. They tend to lie in the second or third interspace, and they tend to most commonly be seen just above a costal cartilage or just superior to a costal cartilage, but they can be seen anywhere along the length of the interspace. This simply shows the most common location inferiorly within the second interspace, just above the costal cartilage. Notice that with spatial compounding, I can outline the capsule of this lymph node better. In older women with right heart failure, you can have tortuous internal mammary veins, so it can be helpful to turn on color or power Doppler to determine the lymph nodes from just a tortuous distended internal mammary vein. Notice the reflection artifact coming off the lung. So here's a case with a high-grade invasive ductal cancer, very gross axillary metastatic disease. These are the most likely cases to have positive internal mammary lymph nodes because you have quote-unquote tumor damming and you have collateral flow around the axillary lymph nodes, which increases the risk of metastatic disease. So in this case, we looked in the internal mammaries, and you can see how large the internal mammary lymph nodes are, much larger than normal, well over the normal 5 to 7 millimeter maximum diameter or 3 to 5 millimeter AP dimension. I don't want you to think that all internal mammary lymph nodes occur only because there's tumor damming. Sometimes with deep medial lesions, you'll get isolated internal mammary lymph nodes, and here's a nice extended field of view showing a gross internal mammary metastasis in the first interspace. This patient did not have any associated axillary lymphadenopathy. Now, why do we care about these level 2 and level 3 lymph nodes or internal mammary lymph nodes? Well, first of all, I want to stage the disease accurately. I want to help the patient's survival improve as long as possible, but it is a common cause of quote-unquote so-called chest recurrence, chest wall recurrence. This is an infraclavicular lymph node. Here's the clavicle, but look at this is a quote-unquote chest wall recurrence. This is a taller than wide irregular lesion with abnormal vascularity that is metastatic breast cancer within a level 3 node. Notice that there's a deeper level 3 node with a rat bite indentation into the hilum. So this lymph node is more abnormally and has perinodal invasion, but it's created a so-called chest wall recurrence, while this one is still within the capsule of the lymph node. Here's a patient with a so-called chest wall recurrence. You can see the pectoralis major in front, the pectoralis minor in back, so we can clearly say that this chest wall recurrence is in fact metastatic tumor and Rodder's nodes. Here's a so-called peristernal recurrence, but again, it's obvious where this came from. It came from the internal mammary lymph nodes and it grew up and around and surrounded the sternum. So so-called chest recurrences arise from unrecognized, unresected lymph nodes. Internal mammary lymph nodes are especially important to recognize, and it matters greatly to the radiation oncologist because in the old days there was always an internal mammary field on the radiation therapy, but there were so many pericardial and myocardial complications from the radiation that they've stopped doing it routinely, and they now reserve this for cases with suspected or proven internal mammary lymph nodes. You can prove these with FNA. I would never do a core biopsy on an internal mammary node, but you can also confirm it with PET-CT. So in summary, we evaluate the lymph nodes fairly aggressively in any patient with BIRADS 4 or 5 lesion in whom we're going to do a minimally invasive biopsy. If a lymph node is positive, we biopsy it and confirm that it's present or that it's negative. But remember that a positive staging ultrasound is always more valuable than a negative. A grossly distended abnormal lymph node that ultrasound leads to biopsy of can avoid a sentinel node procedure, but it can't obviate an axillary dissection. The patient will still need an axillary dissection for formal staging. A negative staging ultrasound or a negative biopsy of an abnormal appearing lymph node is just an extra procedure. The patient will still need a sentinel node procedure if that was originally planned, and if it's positive, we'll still need an axillary dissection. So it's just an extra procedure. The fact that we can do these lymph nodes doesn't mean we should be overly aggressive. We should reserve our biopsy for cases where we're highly suspicious of metastatic disease. We should try our best to minimize biopsying reactive lymph nodes. So the distinction of reactive to metastatic is important. So this is what I want to talk about a little further. There are some things coming down the pike that can be very helpful. One of these is a lymphatic specific ultrasound contrast agent called sinusoid that was actually developed for cardiac contrast, but we find very valuable in lymph nodes, at least in animals, not in humans yet, or shear wave elastography. We hope these two things can help us distinguish reactive from metastatic lymph nodes. Sinusoid has been used in animals in the U.S., although it has been used in Japan and humans. The studies in the U.S. have been done by Thomas Jefferson University, and these images were given to me by Barry Goldberg, so I thank Barry for them. This is injection of a subcutaneous tissues in the thigh of a melanoma pig. This has been used primarily in melanoma, but notice that the contrast rapidly is taken into lymphatics. Notice that they indeed run in the deep subcutaneous tissues near the superficial fascia. This is a thigh, not a breast, but it's similar. It's going up along the spermatocord, this male pig. And we're going to lose it behind bowel gas in a minute, but with graded compression sonography, we'll push the gas out of the way. Now it's lost behind gas. But with graded compression now, we're going to see the cortex of the lymph node show up any second here. And now we're seeing the cortex of the lymph node turning white. So the contrast is percolating through the subcapsular, cortical, and medullary sinusoids and making the cortex of the lymph node white. This has been validated with methylene blue and radionuclide injections. This is showing a methylene blue corresponding to the injection. And notice that the cortex of a pig fills within 2 minutes of injection. So you can get pretty rapid enhancement of the cortex using sinusoid. Notice, however, that we're filling from the inside out, and I told you that the lymph nodes fill from the outside in. The reason for this is that this is the pattern in melanoma pigs, but humans actually indeed do fill from the outside in. When there's a metastatic lesion, what we will get is a defect where there is no contrast enhancement. You can see that the area of no enhancement corresponds to a large area of metastatic disease within this lymph node, and the contrast enhancement corresponds to an area that is not involved by metastatic disease. Now, in a lymph node this abnormal, contrast wouldn't help us because we would know this is metastatic disease and we would specifically target this. But there are many cases where the metastasis is rather small, and there's a lot of normal or even reactive cortex in that lymph node, and were we to target this part or this part of the lymph node, we would get a false negative biopsy. So what this is going to allow us to do is target our FNA or core biopsy specifically to the area of decreased enhancement. And I think this will prove our ability to distinguish reactive from metastatic lymph nodes. The last thing is shear wave elastography. I told you that size wasn't a very good criterion. This is about a 15 millimeter lymph node. Blue in this scale is not stiff, so this is shear wave elastography. It's the opposite of static elastography. But that's also selectable. But the main thing is we can see that this lymph node, which was biopsied and found to be reactive, is not stiff. It's as soft as the surrounding axillary fat. This lymph node, on the other hand, even though it's tiny, only about 5 millimeters, is exceedingly stiff and far stiffer than any of the surrounding tissues. And this was metastatic disease. So we're hoping that this will indeed help us distinguish a metastatic from reactive lymph nodes. So in summary, like wow man, ultrasound of the axillary lymph nodes is way better than CT and even better than MR right now, although sub-millimeter isovolumetric MR may hold some promise in the future. You would still biopsy the lymph node under ultrasound guidance, so you're still going to have to be able to evaluate lymph nodes with ultrasound. Thank you.